All right, changes in specific organs. And I would dare say there is probably no organ in a woman's body that isn't affected by pregnancy. So we will look at the normal physiologic changes of pregnancy. Let's first look at skin. Stria gravidarum. The lay term for that is stretch marks. And it's interesting, women who develop significant stretch marks are probably reflecting changes in their collagen. And genetically, a woman who has stretch marks has a probably less stretchable collagen and has a higher rate of lacerations in childbirth. Here's a woman who's got some fairly prominent stria gravidarum. Now, I've seen some women who in the first trimester already have stria gravidarum. Other women who have twins or triplets in the third trimester never develop them. Why not? Well, here's something that I have for sale. It is called Stretch Mark Cream. Actually, I don't have it for sale, but you can buy it on the internet. And it is an unconditional money-back guarantee. What do you think? I doubt it. Only costs $49.95 for one bottle of it. I doubt it. I think it's probably more genetics. If your mother had it, if your sister had them, you're probably going to get them too. Skin changes, looking at increased vascularity. And we're going to look at spider angiomata, palmar erythema, Chadwick sign. Now, why is there increased in vascularity? It is probably because of the smooth muscle relaxing effect of progesterone, which causes the dilation of the vessels. Here you can see spider angiomata. Let's take a closer look. And here they are. And you can see how they kind of have the spidery shape. What is it that causes this? It is the increased estrogen. If you would put your finger on it, it would blanch as the blood is forced away. So you take away your finger, it comes back. Now, men can also get this. Yeah, men can get this. Under what condition? If they have liver failure, and if they have high levels of estrogen, they will get spider angiomata just like this. Palmar erythema, and this woman really shows it well on this picture. Look at the increase in blood flow to the fingers. A pregnant woman will not get cold and clammy hands. If you're looking for cold and clammy hands as a sign of hypotension, don't look for that in the pregnant woman until she's just about ready to go under, because you have this increase in blood flow. This chart shows the increase in blood flow to the leg, the forearm, and the foot. And there's not a great deal of difference. But look at what happens to the hand. The palmar erythema, significant increase in skin blood flow. And why is this? It's to get rid of the heat production from the fetus, which is transferred out through the mother. We also have increased pigmentation in the skin, and this is often seen in the form of linea nigra. And then we have the chloasma, which is also the skin pigmentation on the face. Here we have a patient who's got significant linea nigra. This is often seen in women who have probably darker complexion, less so in women who are blonde. Does it go away after? Maybe a little bit, but not a whole lot. Here we have chloasma, which is this increase in pigmentation on the skin, and that can be on the face and can be significant. You may get some resolution, but frequently, once you got it, you got it. All right, that was the skin. Let's move on to cardiovascular changes, and we can see changes in the arterial side as well as in the venous side. What happens to systolic arterial blood pressure in pregnancy? It goes down. What happens to diastolic blood flow during pregnancy? It goes down even more. So both systolic and diastolic blood pressure go down in pregnancy. I'll show you a slide of that just coming up next. Venous pressure, central venous pressure does not change. So the CVP if you would take that, should be unchanged in pregnancy. But the femoral venous pressure goes up significantly, 2 to 3-fold. Peripheral vascular resistance also goes down. Now, interestingly, all of these changes are really to enhance the uteroplacental blood flow. And this is a positive thing for maintaining the pregnancy. Here we have a chart showing the change in blood pressure, systolic and diastolic, non-pregnant to 40 weeks. And you see there is a decrease in systolic blood pressure. There is even more of a decrease in diastolic blood pressure. Now you'll see that there will be even at the first trimester, this vertical line that you already have a decrease. It does gradually go up in the latter part of the pregnancy, but if you'll notice, it never is higher during pregnancy than it was prior to pregnancy. It should never go up. Blood pressure never is higher in pregnancy than in the non-pregnant state, normally. This shows femoral venous pressure, and you can see it goes up from about 9 up to 25, almost a 3-fold increase in femoral venous pressure. That's in the lower part of the body. Now, what does that lead to? Varicose veins and hemorrhoids. Here's a patient who is 5'11", who has twins in the 3rd trimester. Would you like to have something like this? This is a patient who is 40 years old and who has just 1 baby. Significant varicosities. I've seen patients who have varicosities so severe during pregnancy, they can't walk. They have to be in a wheelchair. What happens after the pregnancy is over? It typically goes away. Hemorrhoids, no fun. Jimmy Carter, President of the United States, had hemorrhoids. Well, many pregnant women also have hemorrhoids. And that is almost normal. All right, now we're going to look at further cardiovascular changes. We're going to look at plasma volume. Now, plasma volume goes up. It goes up by 50%. Now, the normal blood volume of a non-pregnant woman is about 5 liters. So we're going to have 7.5 liters of blood volume during the pregnancy. Heart rate goes up, and that's a normal change in pregnancy. Heart rate rises. Stroke volume goes up. Now, if we take heart rate and stroke volume, those two together make cardiac output. So heart rate goes up, stroke volume goes up, and then obviously cardiac output goes up. What falls is peripheral vascular resistance. And all of this, again, is to enhance the blood flow across the uteroplacental unit. Plasma volume here, you can see, goes up significantly, even as early as the 1st trimester. Plasma volume goes up. Now, what this slide also shows, which I think is of interest, if a pregnant woman expands her blood volume better, the fetal weight is higher. And we'll talk about this under heart murmurs, which are coming up shortly. If a pregnant woman does not have a systolic diamond-shaped ejection murmur, I'm concerned she hasn't expanded her blood volume and she may have a small baby. This looks at mean arterial pressure and peripheral vascular resistance, and you can see they both go down. This is what happens to heart rate. This is what happens to stroke volume. And this is what happens to cardiac output. Cardiac output is a function of both stroke volume and heart rate. And you can see that even with the 1st trimester, we have a significant increase in heart rate and a significant increase in stroke volume, which then leads to a 40 to 45% increase in cardiac output even by the 1st trimester. So a patient who is barely compensating with cardiac disease, by the end of the 1st trimester, you're going to know it if she's going to have a problem. I had a patient once that was referred to me for a therapeutic abortion, and she was 20 weeks gestation. Now, she had corrected tetralogy of Fallot. And when I came in the office, she was sitting quietly on the chair, and I said, "How are you doing?" She said, "I'm doing fine." I said, "How many pillows do you use when you sleep at night?" "Just 1 pillow." I said, "Do you have any activity limitation at all?" No. I said, do you work outside the home? Yeah, she says, I drive a rapid transit bus. Here she is already at 20 weeks. Is she in trouble? No. She has done well in adapting to the increasing cardiac output and did well throughout the pregnancy. She did not need an abortion at all. Now, when I was in China, some of the traditional methods of making diagnosis include palpating the pulse. Now, you also look at the tongue like this. Now, frankly, I don't know what to look for on the tongue, but they tell me that you've got here the intestines, here is the kidneys and the bladder, here is the spleen and stomach, and the heart is down here. Did you know that? But the pulse is really important. And you notice you palpate in 3 different locations. And there are various things that you will palpate for. There are 9 areas of diagnostic information on each wrist that you will palpate. And once the traditional practitioner has made the diagnosis, they send you then to the herbologist, who will then give you the herbs. You think there's anything to that? Well, let me tell you, I suspect there's a lot more wisdom in traditional cultures than we understand. And I would not poo-poo what they do by any stretch of the imagination. Anyhow, continuing on, cardiac output varies by maternal position. Now here we have a woman, obviously in the 3rd trimester, who is laying supine, and here she is on her side. One of the concerns about laying on her back is what we call supine hypotensive disorder. The inferior vena cava, which is thin-walled, get compressed by the large uterus, and you have decreased cardiac return. The heart can only pump out what comes into it, and so you have decreased cardiac output, and the patient gets faint. And I do a lot of obstetrical ultrasounds because my major area of interest is maternal fetal medicine, and patients who have twins particularly, when I'm doing an ultrasound on them, they're laying on their back. After a few minutes, they say, "Doctor, I think I'm going to pass out." Well, what do? She's probably got an inferior vena cava compression. What we're going to do is to lay her on her side. We're going to lay her on her left side. And when she lays on her left side, the uterus then rests on the aorta, which is thick-walled, high head of pressure. You're not going to get compression of that, and she'll do well. So the supine hypotensive disorder. It's important when we look at cardiac output to indicate what the mother's position is, because if she's laying on her back, you will get a falsely decreased cardiac output. Cardiac output varies by stage of labor. And here we have a table which looks at the non-pregnant, the late pregnancy. Now, what increases the heart rate with late pregnancy? Well, we talked about this. It is increase in heart rate and increase in stroke volume. In the first stage of labor, the cardiac output goes up. What causes that? The pain of labor increases the heart rate, which increases the cardiac output. How about stage 2? In stage 2, it goes up even more. And here we have the patient who is working. She's pushing. She's trying to get this baby out. That increase in heart rate causes an increase in cardiac output. Now, what is fascinating is the greatest increase in cardiac output is postpartum. Postpartum. What is it that causes that increase in cardiac output so high? This is important when we look at postpartum management, because there is the venous sinusoids in the uterus are filled with blood. Once the placenta is out and the uterus contracts, there is an autotransfusion of 600 to 800 cc's of uteroplacental blood, which rapidly comes into the peripheral circulation. Now, if you're giving a blood transfusion and you write the orders, transfuse a patient with a unit of blood, over what period of time? You typically say we're going to transfuse a unit of blood over 1 to 2 hours. How long does it take for this autotransfusion to take place? Minutes. You have this rapid increase in plasma volume, plus you have a loss of the low resistance shunt, and up goes the cardiac output. So the bottom line is, when in pregnancy is the greatest risk of cardiac failure? And it's not in the first or second stage of labor, it is when the placenta comes out. We have many patients who have heart disease who some of the consultants will say, well, they should have a cesarean delivery to protect the heart. Can you prevent removal of the placenta with a cesarean? No. So even with a cesarean, that risk of cardiac failure is increased because of the autotransfusion of blood. Heart murmurs. What happens to heart murmurs in pregnancy? Are heart murmurs ever normal? And the answer is yes. There is normally a mid-systolic ejection murmur. It should not be grade 6, but it should be present, and you should hear it. Here we've got the systole, and here we have diastole. And you notice that this is a crescendo, decrescendo murmur, which is heard only during systole. It goes up in sound, in volume, and then it comes down. That is during systole. And what this is a reflection of is the increase in blood volume and the increase in blood flow across the pulmonary and the aortic valves. And those are normal. But diastolic murmurs, pansystolic murmurs, are never normal during pregnancy. Now let's look at the hematologic changes which occur. And these are significant. Red blood cell mass goes up in pregnancy. It goes up about a third, so let's say 30% increase in red blood cell mass. Plasma volume goes up 50%. So both go up, but the plasma volume goes up more. That results in a decrease in hemoglobin and hematocrit. Now, is that anemia? No. Anemia is decrease in oxygen carrying capacity. When you increase the red blood cell mass, you increase oxygen carrying capacity. So even though the hemoglobin and hematocrit decline, that is normal in pregnancy. And it bugs my soul when laboratories send out their results using non-pregnant reference ranges. Because when you look at the report of a pregnant woman, her hemoglobin may very well be 11, and that's called anemia, and it's not anemia at all. We'll talk more about that. White blood cell count goes up. Normal white blood count during, or in a non-pregnant woman, may be 10,000. In pregnancy, 16,000. Sedimentation rate goes up. Why does sedimentation rate go up? Because your gamma globulins go up. And frankly, all of your plasma proteins go up with exception of albumin. And so when your gamma globulins, your beta globulins go up, sedimentation rate will follow and will also go up. Let's say you're a surgeon and a pregnant woman comes in the first trimester and she has right lower quadrant pain. One of your concerns is going to be appendicitis, right? So what are you going to order? You're going to order a white count or a CBC, and you're going to look at a sed rate. Well, the fact is that normally those are going to be increased in pregnancy. So you really can hardly use a white count and a sed rate for evidence of infection in pregnancy because they normally go up. Factors 7, 8, 9, and 10 go up. Now, what is the impact of that? When you increase clotting factors, the risk of thrombosis goes up. Now, there are lots of other reasons why thrombosis goes up, but one of those is because of the increase in the clotting factors. So pregnancy is a hypercoagulable state. Platelet count really stays within the same range and in a non-pregnant woman. So it's important in pregnancy that we adjust mentally our reference ranges when we look at white blood count, when we look at sedimentation rate, when we look at the factors 7, 8, 9, and 10, and we look at hemoglobin hematocrit, because they are not the same. Okay, this next slide we've already seen when we looked at increase in plasma volume, but you can see that there is an increase in plasma volume which occurs even as early as the first trimester. So here we have an increase in plasma volume, increase in blood volume, and red blood cell mass. And you can see that red blood cell mass does go up even though the hemoglobin and hematocrit will drop. And here is your hemoglobin. Notice in the non-pregnant state, normal reference range is from 12.5 to 14.5. Here we have the first trimester, and you notice how it is already dropped by the first trimester. And where is the lowest point in the pregnancy of the hemoglobin. And you can see it is around 25 to 30 weeks. That's why one of the laboratory tests that we order in the latter part of pregnancy is a cell profile to look for the hemoglobin and hematocrit. Because if she's not anemic by 30 weeks, she probably will not be anemic. Again, to reiterate, physiologic anemia is not a true anemia because we have an increase in oxygen carrying capacity as a result of the increase in red blood cell mass. But because of the hemodilution, we have a physiologic anemia. All right, now we move to the gastrointestinal tract, and there's a lot of changes here that are very troublesome for women who are pregnant. Firstly, smooth muscle wall tone goes down, resulting in decreased motility. Now, what's the mechanism of that? It's probably because of the smooth muscle relaxing effect of progesterone. And progesterone levels are very high because of placental production. So smooth muscle wall tone goes down, motility goes down. Therefore, the emptying time of the stomach, the emptying time of the gallbladder, of the large and the small bowel will also go up, and the residual volume will go up. If you increase the residual volume of the stomach, at the same time you decrease the gastroesophageal sphincter, what are you looking at? Reflux esophagitis. The most common cause of epigastric pain in pregnancy is reflux esophagitis. It's so common, so common. Cholelithiasis because of decreased contractility of the gallbladder, and constipation is a major issue for pregnant women. And if they were constipated before they got pregnant, it's going to be even worse. So what do we want to do? We want to have stool softeners, encourage oral hydration, regular bowel movements. But this is very, very common. Let's look at changes with the lung. If you look at the volume of air that you are moving in and out of your lungs at rest, we call that the tidal volume. Now, if you take as deep a breath in as you can, the increase in the lung volume is called the inspiratory reserve volume. We put those two together and we call that inspiratory capacity. Then you breathe out as much air as you can. That is called the expiratory reserve volume. And when we put those three together, we have vital capacity. Now, there's still air which is trapped in the lung, and we call that residual volume. We put all four of these together, and we have total lung capacity. Now, what happens in pregnancy? This is the non-pregnant woman. This is the pregnant woman, and as you can see, tidal volume goes up. All of the others go down. Inspiratory reserve volume, expiratory reserve volume, residual volume, all will go down. So the main change in the lungs is the tidal volume. The tidal volume goes up. That's the air moved at rest. This is a graph which shows the normal changes in tidal volume, and you can see that they go up. Now, what is the impact of that? Well, let's look at minute ventilation. Minute ventilation is a volume of air moved by the lungs in 1 minute, and it is a product of respiratory rate and tidal volume. You know, a parallel to this would be cardiac output. Cardiac output is a product of not respiratory rate but heart rate, not tidal volume but stroke volume. And that's how we get cardiac output. The minute ventilation is an expression of the volume of air moved by the lungs in 1 minute. Now, what happens to respiratory rate? Now, we know the heart rate goes up. Does respiratory rate go up? No. There's no change in respiratory rate. And here you can see this graphically portrayed. Respiratory rate stays about the same. But what happens to tidal volume? Well, we've also said the tidal volume goes up. So if respiratory rate is unchanged, stays equal, tidal volume goes up, minute ventilation will go up. So tidal volume goes up, but all of the other volumes go down. Now that's pretty easy to remember. Tidal volume is the main one which changes. Now, there are other changes to the lungs. We get a widened thoracic diameter because of the uterus pressing up, and we have a doming of the diaphragm because of the pushing up of the pregnant uterus. Now, if we look at the increase in minute ventilation on blood gases, it is significant. What happens to PCO2 if minute ventilation goes up? PCO2 goes down because you have a respiratory alkalosis. What happens to pH if PCO2 goes down? pH goes up. So we have an increase in minute ventilation, we have a decrease in PCO2, we have a rise in the pH. That is a normal change. If you would get blood gases on a pregnant woman, her PCO2 instead of being 40 is going to be 35. Her pH instead of being 7.4 is going to be 7.45. And that is a normal physiologic change. And when you get blood gases on a pregnant woman, you better mentally take that into account. Otherwise, you may think that there is a problem. Now, if pH goes up, what happens to urine pH? Urine pH goes up too, because when you have the respiratory alkalosis, the increase in bicarb is adapted by putting the bicarbonate into the urine, and the urine, instead of being acidic, now becomes alkaline. And that's one reason why there is an increase in urinary tract infections in pregnancy, because the pH goes up. And that predisposes. There are other reasons as well, but this is one of those for increase in urinary tract infections. So here we have PO2 goes up, PCO2 goes down, bicarb goes down. Normal changes of pregnancy. Let's look at the kidneys now. In terms of renal anatomy, the kidney size goes up, both the length and width of the kidney. The renal pelvis volume goes up. That is the urine, which is in the renal pelvis. And the ureters increase in size. A normal ureter should be about the size of a pencil. In pregnancy, it will be about the size of your thumb. Now, when you take urine, well, actually, if you take any fluid and put it through a larger diameter tube, what happens to the flow velocity? Decreases. So you really have stasis of urine. So you put those two together, increase in the pH, a stasis of the urine, and you're going to increase the risk of UTIs. So here we have the kidney. The kidney length increases, the kidney width increases. And this is probably because of the increased renal blood flow, because of the increased cardiac output. So you have a compensatory hypertrophy. Now what happens after the pregnancy is over? Cardiac output goes back down, and it probably takes 6 to 8 weeks in order for the kidneys to go back to their normal size. Here we have an image of the urinary system, and you can see the kidneys and the ureters and the bladder. The ureter increases in size, and which side does that occur more likely? It is 90% on the right side than the left side. Now, which side do you think pyelonephritis occurs more commonly in pregnancy? 90% on the right side as well. Now, why is that? I don't have any good explanation. Some people say that as the pregnant uterus rests on the pelvic brim, it compresses the ureter and you have reflux. Yeah, but this can happen, the dilation of the ureter, even in the first trimester. So just remember that. This is an ultrasound of a kidney in pregnancy, and you can see the increase in the renal pelvis. So renal anatomy changes. How about renal function? That also changes. Renal plasma flow goes up, glomerular filtration rate goes up, and creatinine clearance goes up. So basically we have increase in cardiac output, increase in renal blood flow, which then increases the clearance of waste products. So GFR, creatinine clearance. What is a normal creatinine clearance in a non-pregnant woman? Maybe 100 to 120. In pregnancy, what do you see? 150 to 180. And that's normal. Because we have this increase in the clearance of metabolic waste, then our BUN will go down, serum creatinine will go down, and uric acid will go down. Now, normal BUN in a non-pregnant woman is maybe 10 to 15, even up to 20. In pregnancy, it should be less than 10. Creatinine in a non-pregnant woman, 1, 1.2. In pregnancy, 0.5, 0.6. Uric acid, non-pregnant woman, 7 to 8. In pregnancy, it should be 4 or 5. So these need to be taken into consideration when you look at the normal laboratory values of a pregnant woman. Glucose in the urine, we call that glucosuria. What happens to that in pregnancy? Normally, it goes up. There is an increase in spillage of glucose into the urine. We call this splay. And when you check the urine, does that mean, if it's positive, that the pregnant woman has diabetes? No. How do we make a diagnosis of diabetes? We measure the blood glucose, not the urine glucose. This is so common. Frankly, I think testing of urinary glucose on prenatal visits is worthless because we don't make a diagnosis of diabetes based upon urine anyway. Now, protein in the urine is a different story. What happens to urine protein in pregnancy? And it does not change. So while glucosuria is common and to be expected, proteinuria is not. Okay, so that's the kidneys, the renal function. Now let's look at endocrine. We'll start out with the pituitary. There is an increase in blood flow to the pituitary, the same as there's an increase in blood flow to the kidneys. What happens to the size of the pituitary gland in pregnancy? It gets bigger. Increase in blood flow to the pituitary. Now, what does that then result in the risks for? If you have jeopardy of the blood supply of the pituitary, let's say you have postpartum hemorrhage, or you have even an antepartum hemorrhage from placenta previa or abruptio placenta, what are you looking at risk of? Sheehan syndrome. Sheehan syndrome. Infarction of the pituitary because of hypotension. And what hormones will be involved? All of your trophic hormones. The most susceptible hormone is going to be prolactin and failure of lactation, which could occur. The next hormones that go is your gonadotropins, your LH and your FSH. And the last ones would be ACTH and TSH. But that's Sheehan syndrome. And there is an increased risk of that because of the increase in blood flow. Adrenal glands. The adrenal gland size does not change. But the production of cortisol in pregnancy goes up significantly. Here you can see the rise in cortisol. So we have an increase in HPL, we have an increase in estrogens, we have an increase in progesterone, we have an increase in cortisol. All of those will predispose to gestational diabetes. Thyroid gland. Let's look at thyroid physiology. Thyroid gland size goes up. Is that surprising? The pituitary gland increases in size. Many of the vascular organs go up. So the thyroid gland size goes up. Total T3 and total T4 go up. Why do the total T3 and total T4 go up? Because thyroid binding globulin goes up. All of your carrier proteins, all of your carrier globulins, whether it's iron binding globulin, whether it's sex hormone binding globulin, whether it's thyroid binding globulin, they all go up in pregnancy. What's the only protein that doesn't go up? Albumin. Albumin goes down. Now, the normal reference ranges for TSH and TRH, thyroid stimulating hormone and thyroid releasing hormone, there is no fundamental change. The free T3 and free T4, the unbound, do not change. And free thyroxine index does not change. So the parameters that we use for diagnosis of hypothyroidism and hyperthyroidism are basically unchanged. So we can use the same reference ranges for TSH, for T3, T4, and for thyroid, free thyroxine index. Fetal circulation. We need to just look briefly at this because there are some very significant shunts which occur, and there are mainly three. There's the ductus venosus, the foramen ovale, and the ductus arteriosus. Now, the ductus venosus takes blood from the umbilical vein and dumps it into the inferior vena cava. The blood from the inferior vena cava will then go into the right atrium. And now we have the second shunt. Blood is shunted from the right atrium into the left atrium. This is an opening in the interatrial septum. The blood goes from the pulmonary artery normally into the lungs, but in the lungs there is no point in the blood going through because there's no oxygenation that occurs in the lungs during pregnancy. And so we have this shunt that takes blood from the pulmonary artery to the descending aorta, and we call that the ductus arteriosus. Now, there are medications that the mother can take which can cause constriction of the patent ductus arteriosus in utero. And that is indomethacin. We'll talk about that when we are talking about preterm labor tocolysis. Okay, so here we have an illustration of the fetal circulation. Here is the placenta. Here is the umbilical cord. There are two umbilical arteries which carry blood from the fetus down to the placenta, and there is one umbilical vein that carries blood from the placenta to the fetus. If you want to assess the metabolic status of the fetus, you want to get blood gases, which would be the best reflector of the fetal status? The umbilical arteries or the umbilical vein? And it's going to be the umbilical arteries, because there is deoxygenated blood in the arteries, there is oxygenated blood in the vein. There was a question on the exam once where they asked on the Step 2 exam, where in the fetal circulation is the highest PO2? And the highest PO2 is in the umbilical vein just prior to entering into the inferior vena cava. So here again, we've got the three shunts. We have the ductus venosus that takes blood from the umbilical vein and puts it into the inferior vena cava. We have the foramen ovale that takes blood from the right atrium and puts it into the left atrium. And so it bypasses the lungs. Blood that does go through from the right atrium into the right ventricle and gets into the pulmonary artery is shunted away from the lungs by going through the ductus arteriosus. There is a difference in the oxygen binding of the fetal hemoglobin and the maternal hemoglobin. And this chart really demonstrates that beautifully. You can see this is the oxygen content of the mother's hemoglobin. This is the oxygen content of the fetal hemoglobin at a given PO2. Now, when I was in medical school, I was taught the fetus lives on the top of Mount Everest. And I've never forgot that, because what it tells me is that the fetus gets by with low PO2 levels without much difficulty. And why is that the case? Well, let's look here. You can see at a PO2 of 30, the mother's oxygen content is less than half of that of the fetus. And the fetus can get by very well with low levels of PO2. And this is because of the oxygen hemoglobin dissociation curve of hemoglobin F versus hemoglobin A. And that brings us to the end of physiologic changes in pregnancy.